Welcome back to the PFC podcast. The views and opinions you are about to hear are the speakers and do not necessarily reflect those of anyone else. Now on to the podcast.
Welcome back to the PFC podcast. This is Dennis, and today I'm with Andre. How are you doing today?
Great. Glad to be here, Dennis.
Well, today's topic is 100% up your alley. We're going to be talking about calcium and trauma, and why do you researchers have to rain on our parade? We thought we knew what we were doing.
Yeah, well, it's an interesting topic. Calcium, trauma, blood, they all seem to go together, but getting it right is not an obvious thing.
Yeah. So, if you wouldn't mind, since you were there at the beginning, like very early in my career, like calcium was like the new hotness, and it just builds and builds and builds, and now we're giving it to everybody who's got a paper cut, and then somebody came along and was like, hey, we probably shouldn't be doing that.
Right. So there at the beginning, I remember a conversation I had with Stacy Shackelford when she was director of the Joint Trauma System. We were talking about blood transfusion far forward. That had progressed quite a bit. In the hospital, certainly operating room, the ICU, whenever a lot of blood is being transfused, people are measuring, all sorts of things, including calcium, ionized calcium in particular. And we watch out for hypocalcemia and always try to correct it. And we asked ourselves the question, are people using calcium? And I know Stacy had her team look at this, and what they found was basically there was no documentation of any calcium being given, at least at the Role 2 level. And so, if it wasn't documented, it wasn't given. So the group of us thinking about this problem thought, well, this should be a performance improvement project. Like, let's figure out, is calcium being given? When is it being given? How much is being given? Let's try to, standardize this training, the guidelines, and so forth. Around the same time, of course, we went from, mid 2000s, we were talking about, hey, plasma with red cells probably better than just crystalloid. Then we had the platelets. Then we kind of went to the 1-to-1-to-1 concept. Hey, what about whole blood? Let's get all this pre-hospital. And so the pre-hospital community, I think particularly when the Rollo protocol came out in, I think, 2014, that this became a question of, okay, it's not just blood we're giving or blood and plasma or what have you. It's the whole package of resuscitative products, right? TXA, certainly. What about calcium? And when we did this audit and found like no documentation of calcium being given, and we started putting this emphasis on performance improvement and trying to make sure that at least it was documented, how much, when, et cetera. This kind of crept into the discussion of pre-hospital and prolonged field care, resuscitation. And we're like, well, maybe it should be in there as well. And then, we got into a lot of discussions about, if you're thinking about giving blood, you should think about giving calcium because it's going to follow naturally. And the long-standing kind of rule of thumb was, if you're not monitoring, you should be monitoring if you can, right? But if you're not monitoring your ionized calcium, you should be thinking, a unit of, a gram of calcium with every 4 units of blood products. And just parenthetically here, there's some misconception some people have about whether all blood products contain citrate that binds calcium, and the answer is yes. All blood products contain citrate. So when you start out with a whole blood donation that then gets turned into red cells, plasma, maybe platelets, or cryo, it all gets collected in CPD or CPDA. And what is the C? It's citrate. And if the product is collected by apheresis, typically with ACD as a anticoagulant, what's the C? citrate. So all of it contains citrate, all of it binds calcium. And it's there, and the citrate is there in excess to get all the ionized calcium. Why? So the blood doesn't clot in the bag. All right. So that was like adding citrate was the concept that allowed us to have blood banks in the first place. Right. That was like the seminal discovery of like, oh, here's a way to not have the blood clot. So, since it's there in excess, when you transfuse it, obviously you're going to bind some calcium in the patient as well. This was pretty well documented, in the early 70s. People did studies in the operating room, give a unit of blood, watch the calcium drop, add some calcium, watch calcium go back up. Everything is good. So, pretty well understood effect. Give blood, you will bind ionized calcium, you will cause hypocalcemia. No question about it.
So, I mean, kind of, I guess, so what? Like, I have calcium on my bones. Like, I drink plenty of milk. Everything should be fine. Like, what does calcium have really anything to do with trauma?
Well, it's a great question. So, you do have calcium in your bones, and your parathyroid gland is going to sense low ionized calcium, secrete parathyroid hormone, and that's going to start raising your calcium very quickly. However, the reason we care about it in the short term and why we supplement the calcium and try not to get into that loop is not because of bone health, it's because of cardiac health. So basically calcium, extracellular ionized calcium, controls cardiac repolarization. So if you're low in your ionized calcium or plasma ionized calcium, you have delayed repolarization. In other words, you have a prolonged QT. And if you think about all the drugs that prolong your QT, they all come with that black box warning, may cause arrhythmias like Torsades de Pointe and also VTAC and VFib. So that's, bad. By the way, though, if you have hypercalcemia, you know what happens to your QT? It shortens. It accelerates repolarization, which can also provoke various arrhythmias. So the point is that you have this eucalcemic band that your heart likes to bathe in, and when you get outside of that band, bad things can happen. And so in trauma and other acutely ill patients, we try to keep you in the normal physiologic ionized calcium band to minimize the risk of adding, another problem to your existing problem, such as an arrhythmia. So that's why we care. The other reason is that calcium is really important for cardiac contractility. That's an intracellular thing. And then it's also important for the contractility of the smooth muscle cells in your blood vessels. So it's important for vascular tone. So hypocalcemia reduces cardiac contractility, vascular tone, and makes the heart more irritable and prone to arrhythmias. So generally, no good in a patient who might be hypotensive and prone to arrhythmias because of hypoxia or tissue hypoxia due to hypoperfusion, et cetera. So that's the so what.
Now, are these things, well, let's get into like the evidence, I guess, of, hypocalcemia, because like for a long time, it was just known, like if you're a trauma patient, you are hypocalcemic. And now it seems like other evidence is saying, well, that's not necessarily true. Sometimes you can be a trauma patient and hypercalcemic at the same time. So, I mean, are these different trauma patients, or like why is there such a big difference?
So, as I mentioned, that it's been known for a long time that blood transfusion can transiently drop your ionized calcium. People got started measuring calcium abnormalities in trauma patients at an observational level. A couple of studies have come out, several actually. Basically, there's a fair amount of, about half of trauma patients, depending on how you define a trauma patient, but we'll say, level 1 activations, that kind of thing. I mean, people who are seriously injured, right? We're not talking about a broken ankle. Not that anyone wants a broken ankle, but I was just saying, seriously injured patients, about half of them, a little more than half, come in hypocalcemic. And we know that when they get blood products, they tend to get more hypocalcemic. And so this has led to interventions of sort of, rule of thumb, after 4 units of blood, give some calcium, right? So people started studying this, and what they found was that hypocalcemia is, the most common calcium derangement in trauma. However, there are patients who are hypercalcemic, and it turns out that their outcomes are even worse than patients who are hypocalcemic. In a recent paper that we published out of BAMC, UT Health San Antonio, and University of Colorado Anschutz, study led by Steve Schauer. We found that basically it was around 11, I think 0.8% mortality for patients who were hypocalcemic. Patients who were eucalcemic had a mortality of 4%, and patients who were hypercalcemic had a mortality of 22%. And so basically, if you had a derangement in calcium, you're more likely to get blood, you're more injured, and this is associated with badness. Now, how much, was the blood sort of driving the calcium derangement? So we looked at, how much blood did the patients who are hypo versus hyper get? It was pretty similar. A little bit percentage, maybe more got blood, just a little bit that were hyper. But in another observational study that was, similar, looking at trauma patients admitted and looking at their, that other group found that patients who were hypercalcemic tended to get more blood products and more calcium. Interestingly, more calcium supplementation, and they had worse outcomes. Now, here's the problem with all of these observational studies. Well, did you get more calcium and more blood because you were sicker in a way that, trauma registries and so forth don't really capture? So there's that risk that this is just kind of a, confounding by indication, where, it's kind of like those studies that show if you get blood, you do worse. The answer is don't give blood. It's you did worse because you were sicker, and people were trying to rescue you with the blood, right? And so were they trying to rescue you with the calcium? That we don't know without a randomized trial. And that's what we are lacking right now. But what we do know is that being hypercalcemic is actually worse for you than being hypocalcemic.
So I guess right now, TCCC guidelines are, after your first unit of blood, give a gram of calcium, which is pretty different than before, where it's like somewhere between 2 and 4, give a gram of calcium. So it seems like if you add this up, it can be a lot more aggressive than, before. They didn't say every unit of blood give a gram of calcium. They just said after the first. So I would sometimes you have to actually read the entire sentence. But do you think that could be too aggressive? And again, gut feeling, not based on clinical data.
The reason it was written that way was, again, to kind of correct a perceived omission, a tendency towards omission. People weren't even bringing calcium in aid bags, so they wouldn't even, if this is the prolonged field care podcast, right? If you're sitting on a patient for 72 hours, theoretically, whatever, and you're giving a whole bunch of blood and other stuff to them, and you don't have the calcium, could that cause you a problem? Should we kind of push people in that direction? That was the intention of that. In light of this recent data, it does kind of make you wonder, like, first of all, should you be giving any calcium without monitoring? Is after 1 unit really appropriate, or should it be after 2 or 4 or something like that? I mean, there's enough observational data out there to suggest that, again, half people come in hypocalcemic, they get blood. Giving calcium to them typically does not correct that hypocalcemia very quickly. And so it may be okay to do this, but we don't really know. I would say that, it might be worth re-looking at this for TCCC and coming back with, maybe more of a, hey, if you are going to be in a prolonged field care scenario, try to bring an iStat with you. Okay, that could be a very popular suggestion, but, try to monitor, maybe particularly at a rule 2 where that could be done more feasibly. And then maybe back off the 1 unit and maybe go for a little bit later. I mean, part of the problem is, are outcomes purely driven by cardiac repolarization and smooth muscle cell repolarization in vascular tissue? I mean, by the way, there's CNS effects. I mean, your whole nervous system basically has the same repolarization issues. How much does how much is driven by all of that, or how much is also driven by other processes in the cell where calcium acts as a second messenger to all kinds of signaling processes, including cell death pathways and inflammatory pathways? And if we add calcium, are we adding fuel to that fire? And does that explain why, potentially being hypercalcemic could drive worse outcomes? But again, we can't even really say that the hypercalcemia per se is what's driving the mortality, because this is all observational data. It's associated with increased mortality. There are reasons to think why it might be associated with, why it might be causing increased mortality, but we don't really have a firm grasp of what's the most important thing biologically in the patient at any given point in time vis-a-vis the calcium, right? At some points, if myocardial contractility is so off, or you're so hypocalcemic that your QTC is stretched out to, I don't know, 500 milliseconds or whatever, maybe you do need to rein that in urgently and not worry about pro-inflammatory effects or what have you, right? But without being able to monitor all these things like you would in an ICU, it would be nice if perhaps the DoD could fund the Lights Network to study. And I think actually they may have actually a trial on this now that I think of it. Calcium early or not. That might actually be in the works. So, but maybe we'll have an answer on that. But I think we need some RCT data to help guide us on this. For our friends out there in the field right now, I guess what I would say is I definitely would not give calcium before giving blood. I would give it after giving blood products, at least 1 unit. If you somewhere between 1 and 4 units is probably okay. Although I'm doing a lot of head bobbing and hand waving because nobody knows. Fortunately.
So I think, I guess what I would like to know, because you spend time in the hospital, you've treated real patients, and I'm sure you've given calcium at some point. Let's say you have a trauma patient. The hemorrhage is controlled. We are doing our resuscitation with blood. What would make you want to give this person calcium? Is it just kind of like, well, we haven't given calcium, so why not? Or is there something about them that tells you I should be giving it? Not the iStat. That can't be your answer.
Well, I mean, I think there's, inevitably that consciousness and, in the back of your head that says, I've given a whole bunch of citrate. I'm going to cause a problem here if I don't give some calcium to fix that. Lack of response to resuscitation, maybe thinking about issues like contractility and vascular tone could certainly be a driver. Sometimes people ask me the question about what about coagulopathy? Your ionized calcium has to be below like, 0.7, 0.6 to really see dramatic effects on blood clotting. And you're going to see all kinds of problems before then. So that is not really a driver for me. Um, you know, I mean, if patients in PEA arrest, obviously you're kind of going through your algorithm of like, well, what could be driving this? Let's try some calcium. If you want to keep them out of PEA arrest, though, right? So, so this is the other thing that motivates you is like, how do I avoid the PEA? Well, you know, I'm thinking about electrolytes, and I kind of will want to know what the iCal is.
I'm sure you
um,
do, but in this scenario, there is absolutely no ability to know any of the electrolytes.
yeah. Well, I mean, then you're stuck with sort of empirically, kind of, pulling things out of physiology, right? So if you're given a lot of blood, you're going to need to give some calcium, and then certainly, I think the rule of 4 units, per gram of calcium, or give 4 units of blood and then give a gram of calcium, is an old rule of thumb, but it's if you did that, you probably won't be faulted for doing it. If you gave a calcium a little bit earlier, that's probably not wrong. If you've got a patient you've given a ton of resuscitation to and they're just not responding and you don't know what else to do, well, it sounds like they're dying. You may as well give some calcium and try it, right? Of course, I'd also be reaching for other things like epi and such at that point. Um,
Because this kind of reminds me of another conversation I had with a trauma surgeon, Max Shirkin. We were talking about blood and how quickly a trauma patient can respond to even just a small unit, a small volume of blood. They can really jump back uh, their pressures, right? Because everything's so squeezed down. And so, but all our guidelines is like 1 unit. Give 10 units. Give like it's whole units. And that it's very convenient on the logistic side, but you actually have to monitor your patient to take them to an actual place. All of our guidelines, same with calcium. Like, I guess I'd be setting you up to ask you what's the dose, per kilogram for calcium, because we both looked it up and there is none. So would you be wrong? How about this? In that same situation, it's in the back of your mind, like, man, I've given, 2, 3, 4 units of blood. It seems like he's getting better, but I would think he would be getting much better than he is. Right? There's something that's telling you that there's something off. I want to give calcium. Is there anything, like, is this a hypocalcemia? Is this something I need to fix rapidly? A patient loses the airway. You have to establish it rapidly. Hypocalcemia, could I start with a slow push and give half a gram,
yeah,
a
totally.
quarter of a gram, and see if, like, hey, things are getting slightly better. Let's continue, right? Until
Yeah,
there's a plateau of some kind.
I think you could totally do that. And I think you look at the patient too, and how big is the patient, right? Same thing with the blood products, we just go with units. In peds, we go with, mgs per kilogram body mass. And we do that in oncology too, because too much chemotherapy, bad. Uh, you got to get the dose right. And so, there is such a thing as circulatory overload, and there's probably, and there's certainly calcium overload, like we just talked about. So I think if you're not sure, um, you know, hypocalcemia is something that should be reversed relatively quickly, but it's not the same thing as VFib and, throw paddles on them. It's more like, well, slow push over 5 minutes or something is totally reasonable. And you can start with half a gram or a quarter and then, see what happens and titrate up. And the other thing is that if the patient is in extremis, well, you know, got to start moving, right? So the other thing I would just say, though, that is really important for people to realize is, um, how you push these things does matter. Calcium chloride, as I'm sure many on this podcast know, is a really bad vesicant, and you definitely want to make sure that your IV is patent, flushing, drawing. Like, you don't want to be extravasating that, because I mean, if the patient's about to die anyway, well, okay, that's one thing. But if they're not, and they live, and they have this huge, like, soft tissue injury that you have to take a shark bite out of their arm because you destroyed all that tissue with calcium chloride, that's not great. Calcium gluconate's definitely much safer. Remember, it's 3-to-1 dosing, 3 times the gluconate as you would give chloride. But I just want to throw that one caution out there.
Sure.
Yep.
So just a quick note on that.
Mm-hmm.
So we don't do central lines. It's all peripheral sticks.
Mm-hmm.
What I'll do is I'll take a 10 cc syringe, and if this is an access point that I think I'm going to use to push calcium or epi or something dangerous, I will slam 10 cc's of saline, and if I see this big balloon, then I know that's not good. But I don't know of a better or faster way to check if this is like a patent flowing solid IV that I can put something caustic in.
Well, I mean, you could push a couple cc's in. It goes in smoothly, no problem. You could pull back. Do you get a blood return? You get a blood return. It it flushes and draws. That's great. Push the rest of that in, and then go ahead and put your your syringe with the calcium as ready to go. Must it draw back? I mean, if it doesn't, it may be one of two things. You're in the sidewall, you're on a valve, or maybe it's tenuous. So I would feel more comfortable knowing that you've got flush and draw before you put calcium chloride through that thing. And the other thing is, it also suggests that you're in a big enough vein that you have less risk of thrombophlebitis. I mean, so if again, I know it's a life-saving maneuver with critically ill patient and so forth, but in the field, it's sometimes hard to guess, these things. And if you're just not sure of your, particularly, I mean, people are using IOs. I don't know that I would necessarily use calcium chloride through an IO. I probably would not do that. I would really try to, because it's going to definitely cause some necrosis in the bone marrow, and that could get ugly, especially if it gets infected and so forth. I would try to use venous access if at all possible. Highly favor venous access for this in a large vein, flush and draw if you're using calcium chloride, sorry. If you're using calcium gluconate, you can it's not quite as dangerous. And you can get away with, maybe taking more chances there, but I would be careful.
So since we're talking about end states giving calcium, like we mentioned, there's this like U-shaped bell where you're trying to hit the middle somewhere without any monitoring. You're slow pushing calcium, right? You're kind of trying to feel your way. When would you say, hey, things are good enough? Remember, you're the doctor. I'm just an idiot.
There's, without monitoring calcium, there's really no way to know, because, as I said, all these observational studies show you do worse with hypercalcemia, and that probably is driven by people giving calcium. But is it they're giving the calcium because the patient's doing worse? I mean, it's like in refractory shock, and they're trying everything, and hey, let's raise the blood pressure by giving them more calcium. Well, is the calcium the problem, or is the problem that they were in refractory shock? I don't know. So, if the patient's in refractory shock and you're sitting out there in the middle of nowhere, and you're like, well, I gave all my blood, I gave one thing of calcium, I gave them the TXA already a long time ago, What the hell? I gave them 500 pills of something that I had, crystalloid or what have you. I got another amp of calcium. Helicopters aren't going to be here anytime soon. MAP is 35. Nobody's going to fault you if you just go, well, see if a little more calcium works. Or you already gave you any epi or vasopressin you had or whatever. Okay. In a situation like that, it's like, whatever. But presumably if you're kind of in okay, I'm treating, there's some response, they're not like maybe stable, but like, not actively dying in the moment. I might just kind of stick with somewhere between 1 and 4 units of blood products, give no more than a gram of calcium for that much blood, unless they enter refractory shock and you're kind of in the throw the kitchen sink at them because they're dying in front of you. The one other thing I'll mention, what if all you had was calcium? Should you just push some calcium? So calcium used to be in the ATLS guidelines back in the 70s for exactly this eventuality, and it was removed because there was a small clinical trial done in Minneapolis, I think in 1974. I'll have to find that reference again, but basically, it actually made outcomes worse. In animal studies in trauma and hemorrhage that we did at the ISR, we had a rat trauma hemorrhage model where we basically achieve a low systolic blood pressure and kind of hold them there for an hour before resuscitation. It was kind of this like, what if you're not resuscitated for an hour? What interventions besides blood can you do to help the patient? And then they get their shed blood back. So whole blood resuscitation, basically an hour later. And giving calcium in that interval was 100% lethal. So giving calcium, and obviously we dosed it to like rat body weight, not, like we said, okay, if we're going to give a gram to a human that weighs 7 kilos, blah, blah, blah. And then we kind of scaled it down to a rat. Giving rat, calcium to a shocked rat without other resuscitation was not good for the rat. And apparently it was not helpful in patients with cardiac arrest either. So yeah, I probably would not give the calcium unless you're given products. Bottom line.
I mean, I think that makes sense to me. You make an organ work when it's not perfused, and it's a real good recipe for infarction.
Yeah.
Yeah. When it comes to calcium, like if you're giving somebody advice about the use of calcium, kind of like you are now, what would you give it? Like, when should I give it? How fast should I be giving it? When do I stop giving it?
So, I mean, in the prolonged field care setting, I would consider giving calcium to a patient I was giving blood to. So trauma patient who requires blood-based resuscitation or some other hemorrhage patient. I mean, you may find yourself taking care of whatever. Anyway, if it's a major hemorrhage and you're giving them blood, and you think you're going to give them more than 1 unit of whatever blood product you have, whether that be whole blood, plasma, dried plasma, liquid plasma, whatever you have, red cells, doesn't matter. 1 unit or more, well, beyond 1 unit. I would even say if you think you're going to give them more than 2 units. I think if you give them 2 units and you don't give them any calcium, I think that's okay. Particularly if evacuation is going to be relatively rapid, or they stabilize and, they wake up and they ask for a cigarette, like, okay, probably they don't need any calcium. But assuming you're going to give them more than like a couple units of blood product, and this is a sick patient, I would consider giving him calcium then. I would give no more than 1 gram. I would consider giving less than 1 gram, kind of a phased approach, depending on the size of the patient, depending on how sick they are, 250, 500, 1,000, milligrams, and look at response, and make sure it's given it through a patent IV that flows and flushes and withdraws. I would avoid doing calcium chloride in an IO. I think that's probably going to cause problems. Again, in extremis is one thing, but avoid it if you can. Good, and try to avoid extravasation injuries. I would probably not give more than 1 gram for every 4 units unless you have the capacity to monitor. I would actually, look at the overall fluid status of the patient too, particularly if you have a scenario where you've got like hemorrhage control, they lost a lot of blood, leg blown off, bunch of tourniquets on there, bleeding stops, good hemostatic dressings, you resuscitate, blood pressure comes back up. It took maybe 4 units. You gave me 1 gram of calcium. At that point, I would really be less worried about the calcium and just, and make sure that their overall bleeding is controlled, that they've got enough, some IV fluid just to kind of for insensible losses and so forth, keep them hydrated. Again, as long as they were clinically stable, would leave them alone. If they spiral down on you and you've, as I said, exhausted kind of all other things and you're not quite in PEARS, but you're getting there. Yeah, I mean, it's in the algorithm. You can try calcium again to try to keep them going. I think that's kind of how I would do it. I'm not sure that there are clean stopping rules. It's kind of like, what's the physiology showing you, By the way, if there's no response to calcium, then I would probably stop, right? How fast to give it? Slow IV push. I would not rock the boat too quickly on this. Slamming it in is probably not the best thing to do, especially when you have no idea where their starting level is and where they're going to end up. So given a little bit of equilibration time, and also if you really push it in fast, you're more likely to dislodge a catheter and cause an extravasation injury. So nice, slow IV push over minutes, 5 minutes, I think is a reasonable approach.
Very good. Well, awesome, Andy. I really appreciate you jumping on.
I really enjoy the podcast. Love talking with you, Dennis. And I hope we can continue to develop the science in this area to better support guys at the tip of the spear. And, we'll keep working on it.
That's it for today's podcast. Make sure to go to our website, www.prolongedfieldcare.org. Check out our free downloads and a ton of other helpful information. Grab a bag of our fresh roasted PFC coffee, links in the description below, and stay on the bleeding edge of combat and austere medicine. This is Dennis for the PFC podcast. Out.